So my name's Jaspal Ricky Singh. I live right here in New York City. I recently became the vice chair of rehabilitation medicine at Weill Cornell. So we're located in Manhattan. My background is physical medicine rehabilitation. So I'm a physiatrist. I think that kind of lends nicely to pain management. I know there's been discussions about what do we call ourselves? Pain management, pain medicine, pain specialists. And my specialty is focused on function, getting patients back to doing the things they like to do, mobilizing them, decreasing their pain and symptomatology so that they can live the life that they want to live. So my role at Weill Cornell has been largely interventional spine. I became the director of interventional spine a few years ago in my department. And then, like I mentioned earlier, they gave me a little administrative position as vice chair of the department this summer. My clinical interests, my research interests focus primarily around regenerative medicine. And honestly, I got into that field or that subspecialization kind of from apprehension about what we were doing to patients, what therapies we were offering them. There's a lot of presentations on regenerative medicine and platelet-rich plasma, bone marrow aspirate concentrate, like this is revolutionizing the field. And I kind of got into that specialty thinking I'm going to study it, and if the data is negative, I'm going to publish that. I think a lot of us kind of put the horse before the cart, and we were just intervening while we were sitting there and academics waiting for the data. And that's what I was doing. I was waiting for the evidence, but I realized if I'm not part of that evidence, if I'm not on the front line, then I'm going to kind of miss the boat. So that's where I really pushed my faculty and my group and even my clinical practice to start doing these procedures, but doing them in a fashion where I could study the results. So my interest clinically is right now intradiscal therapies. I think this was an area, especially in back pain and pain in general, where we didn't really have good treatments. If this was 15 or 20 years ago, I think the patient would end up with a spine fusion. And nowadays, most of our spine surgeons, orthopedics, and neurosurgeons aren't fusing these patients, and they kind of have nowhere to go. So we offer them ablations and radiofrequency treatments, physical therapy, of course, medications, which obviously in this day and age we have to be a little careful with. So that kind of leaves the disc with no other option. And there have been a lot of therapies that have gone into the disc, from IDET and biaculoplasty and methylene blue and fibrin sealant, and a lot of them kind of haven't worked. And right now we're sitting on a therapy of bone marrow aspirate concentrate that looks promising. My apprehension is that we're delivering this care, and there's many phase 1 and phase 2 studies out there in physicians' own practices that show it works well. And docs are claiming this is a home run. This treats discogenic pain. But what we haven't seen is real large-scale phase 3 trials. Where's the multi-center trial? And that's kind of where I want to push the next phase of this therapy. Otherwise, it's going to fall by the wayside just like everything else. So I want my colleagues here at ACIP and other societies, SIS and NAS, we need to collaborate. We need to do a large multi-center prospective randomized study on bone marrow aspirate for discogenic pain. We don't have one yet. I think we need one as a community of pain specialists. The public needs one so we can offer them real live data and not just, like I said, it's phase 1, it's randomized, but it's not multi-center, so we need to really fix that aspect of delivering this data to our cohort.